Morning, everybody. Welcome to Grand Rounds. Next week, our Grand Round speaker will be, Richard Kogan, who is going to do West Side Story, the mind and music of Leonard Bernstein. So that's, I think people are familiar with Richard, but anybody who's not, he's like a world-class concert pianist who moonlights as a psychiatrist. And he does these pathographies of composers as well as performing a lot of their works. So it's really extraordinarily not just informative but entertaining. A couple of announcements, all good things. Reuben Robbins received a R01 for $2.3 million from the NIH for his work on improving assessment of neurocognitive impairment among perinatally HIV-infected youth. Robert Remian, who succeeded with Claude Mellons, the leadership of the HIV Center from Anke Ehrhardt, submitted and now has been received a NOGA for a renewal of their P30 Center grant for HIV clinical and behavioral studies. It's amazing. They've had a 30-year record of continuous NIH funding. And although Anke was the sort of original PI, she transitioned the leadership, and without missing a beat, they've sustained its funding record, as well as also the research and productivity. Our own Dave Ladoff, a PGY4 chief resident, was appointed associate editor of the American Journal of Psychiatry Residence Journal. Dave, does the Residence Journal have any sort of formal interaction with the main AJP? Do you know who the new AJP editor is? Was it announced? Was it announced?
Yes.
So Ned Kalin is the new AJP editor to take over, I think in July, maybe. Also, Angela Coombs, who's a PGY3 and a rising, soon-to-be chief resident, has been accepted by the APA into their SAMHSA Minority Fellowship Program. And that's an excellent time to be in that program because the SAMHSA is under new leadership with Anita Everett and Ellie McCants-Katz. And finally, Patrick Hurley, a PGY2, has been accepted by the APA into their Leadership Fellowship, which aims to develop leaders in the field of organized psychiatry by providing opportunities for trainees to engage in various national level types of experiences. So congratulations to everybody. Our Grand Round speaker today is one of our own faculty, relatively new given the duration of longevity of faculty at Columbia and NISBE, and that's Terry Goldberg. Terry hails from New York, but went to college and graduate school at the University of Michigan in Ann Arbor, where he received a BA in psychology and then a PhD in educational psychology, and his thesis was a neuropsychological approach to performance and selected functions of cerebral palsy children with left and right hemiplegias and specific learning disabilities. You know, there's a center here, an endowed center for CP. I forget the guy's name who heads it, but individuals who are still experiencing brain development. So Terry is really now engaged in a variety of fronts
and my wife, Concha, did a lot of the heavy lifting on some APOE work that I'm going to touch on. I almost said that she was my ex-wife. So, as a lot of you may recall, the gentleman on the left scored 30 of 30 on this well-established legacy method of screening of dementia. Reactions. First is, okay, what's wrong with the test? It must be the world's most insensitive test. It is at least 1.5 standard deviations below. But, this is a big but, they have well-preserved everyday function. I'm going to come back to this in some of the work we've done on functional competence.
Is the 1.5 standard deviation impairment like senior moments or senior?
No, on formal test, quite significant senior moment. And then I'll also talk about individuals with Alzheimer's, multiple cognitive. I'll talk about cognitive domains. They are predictive of progression. I'll get into the study in a little bit that kickstarted this whole line of research. And with an emphasis on earlier treatments and more intact subjects, the established measures designed for Alzheimer's disease proper are fundamentally going to be too easy and too coarse for more or less intact individuals. And last, cognitive and functional co-primary endpoints are mandated in AD trials by the FDA. So this is not trivial. Okay, so let's talk a little bit about biomarkers and cognitive markers in the Alzheimer's disease spectrum. They are relevant to understanding AD. They have something to do with the neurobiology, staging, prediction, treatment response. They include regional brain volumes or cortical thicknesses. They also include CSF measures of tau and A-beta 42. They now include PET imaging measures of amyloid and tau. There are also cognitive markers and various constitutional risk markers, including ApoE, a gene, the variant E4 is known to increase risk of AD. The problem with the field, as I saw it when I came to this field, very late, but I didn't come to it with certain preconceived notions or implicit biases. So I had my own, and that's a different story, but there seemed to be a lack of studies that examined these in combination. As a matter of fact, as best as I could tell, there was really only one study that I thought did this adequately. That was a study from here, from Devanand and Madney. It's a large sample. The data were uniformly and prospectively collected and had a whole range of biomarkers and established cognitive markers. So what we wanted to find out were what were really the best predictors of progression from amnestic MCI to Alzheimer's disease dementia. We took an unbiased and comprehensive analytic approach using within-family biomarker and cognitive marker analyses to find winners in each family, and then in one large multiple regression compared who was the winner among these winners. We used odds ratios, pseudo-R squares in our logistic regressions, and also effect sizes. We had a very large sample of MCI converters and non-converters of over 300 individuals, and that'll be the focus. So what did we do? We had these families of biomarkers, including MR, volume and thickness measures. We had CSF measures that we looked at, and we saw which was most predictive of the MRI measures, which was most predictive of the CSF measures, what was most predictive of FDG PET, and then what was most predictive in cognition in terms of identifying those MCI individuals who progressed all the way to Alzheimer's in a 2-year period. And what we found, and this is a study that was in JAMA Psychiatry several years ago, was that a measure of verbal list learning and a measure of logical memory were highly significant predictors, as well as one structural imaging marker from the left middle temporal region, not medial temporal, but it was actually lateral temporal. And these, in concert, gave an ROC curve with an area under the curve of 0.8. Quite good, and you could see that nice. We did a follow-up study of looking at individuals who converted in a 4-year period, and about 50% of the sample did, and the measures were the most significant, even 4 years on. Now, I should say in univariate analyses, biomarkers did, in the end, to reflect on this, that science, unarguably, I think, is a reductionistic game. But science is also an empirical game. And these data at least indicated to me that we should move forward and look very carefully at the cognitive measures because they seem to have great utility. Okay, so where did we go next with this? Well, we took on something maybe surprisingly simple, but maybe not so simple. We wanted to look at probably the most utilized cognitive measure in the world, orientation from the mental status examination. Probably most people in this room have administered it. It involves asking a person, do they know the date? Do they know the day of the week? Do they know the year? Do they know the season, etc.? And there were two salient features that motivated us. First, no one really understood or had looked at, I should say, had looked at the neural underpinnings and the cognitive underpinnings of orientation. So what does orientation really mean? Most people say when they see a person who's disoriented, oh, that's bad, or when they see a person who's oriented, oh, that's good, and stop there. We wanted to look below that and see what the substrates of orientation were. And we also had noticed something that, to me, was a little disturbing, and that is in composite neuropsychological test batteries that were being used in the preclinical period in individuals who were basically cognitively intact, orientation items were a major player in these batteries. And my concern was psychometric, that there might be a ceiling effect. And hence, orientation would not be particularly informative. So we looked at these data in two ways. First, what are the behavioral neurosubstrates of orientation? And my thinking going into this would be it could be something that would involve some prefrontal function, some higher integrative function in the sense that there was a need for updating, some spatial awareness, and also some memory. Turned out differently. That when we looked at a whole plethora of cognitive markers and biomarkers, what we found really that the only predictors of orientation had to do with the neural substrates of episodic memory, including the hippocampus and entorhinal cortex, and maybe inferior temporal cortex on structural MRI, and cognitive predictors that generally involve memory, including memory for stories and verbal list learning. So it seems that if you really want to know what orientation is about, it's about memory. And there's nothing particularly complicated about. Perhaps a little bit of semantic knowledge is engaged. For instance, a person could determine the season of the year knowing it's 90 degrees out. But in general, it's about memorizing, in a sense, the day of the week, the year, the place you're at, after being told where you're going, etc. Now, on the other side of this coin, and there's always another side, we wanted to look at the psychometrics of this test because, like I said, it's going to be used in these preclinical AD clinical trials. Is this measure informative in people who are intact? And basically, it's not because of extreme ceiling effects. So once you look in healthy controls, about 80% get a perfect score of 10 of 10 of the orientation items on the mini-mental. Even in MCI subjects, about 40% get a perfect score, and another 30% only miss a single items. So in terms of the actual fitness of orientation being used in clinical trials of relatively intact individuals, we don't think it offers a lot. And I think you should be wary when you see so-called composite batteries that use it. Okay, so let's go on to something maybe a bit more contemporary, and that is working memory and executive function compromises in amnestic MCI. And remember, the individuals with amnestic MCI are diagnosed on the basis of their memory. They may or may not have executive function impairments, okay? We wanted to see how frequent such impairments might be, what the severity of impairments might be, what their associations with frontal lobe atrophy were, and also what might the associations with functional competence be. And this turned out actually to be the largest and most comprehensive study in the literature. So what we found first in the dozen measures of working memory or executive function that we administered to a group of, I think about, what, I can't see well, 50 MCI and another 60 or so AD subjects, what we found was this very nice stepwise pattern of individuals who were healthy doing the best, individuals with MCI doing poorly, but not as poorly as those with AD. We also found that there was a very interpretable factor analytic profile of our measures that I think you could take out of here and even think about using clinically in terms of what are the kinds of tests that get at various types of executive dysfunction or working memory impairments. So one factor had to do with executive function. That included Tower of London, a problem-solving task, letter number, manipulation condition, I'll come back to that in a minute, and the NBAC, I'll come back to that. There was also a simpler working memory slave system factor that just involves simple repetition, as in digit span. There was also, and this is important, a trail-making factor, and I'll talk about why it does look frontal. And just to show you that our factor analysis was not particularly rarefied, there was also a strong episodic memory factor. And let me talk a little bit more. The NBAC is a measure of updating, management of interference, and working memory. I developed this at the NIMH. Letter number sequencing is also a test I developed with Jim Gold. It involves saying a short sequence of numbers and letters and then asking the subject to say back the numbers in ascending order and the letters in alphabetic order. So this is a classic executive function task because it involves simultaneous storage and manipulation of information. Psychological Corporation took this test and put it into their WACE IQ tests. Unfortunately, we didn't get paid for that because it was in the public domain. We were working for the government. It still rankles. So what about these amnestic patients? Do they do well on executive and working memory tests, or do they not do well? What's the frequency of impairment? So, as you might expect, the modal frequency of impaired tests for healthy controls, that's the EHC, Elderly Healthy Control Group, was 0. For MCI, the modal number of impaired tests was about 5, and for Alzheimer's patients, the modal number was about 8. So yes, impairments are quite frequent. Yeah, Jeff?
How stable are the performance functions or impairments?
Well, they're quite stable, and as a matter of fact, they generally worsen over time. Yes, some MCI individuals will stay stable for several years, but they'll stay stable in the impaired range. In Alzheimer's, they may stay stable, but they'll also eventually progress. So these impairments will generally get worse as neurodegeneration worsens.
Yeah, I guess what I'm saying is that, and maybe you haven't covered all the more recent ones, not that they're necessarily any better, but if you're saying that predictors of people who have mild MCI of who progresses to what's likely kind of an inexorable dementia,
Yes.
that's pretty serious. So if you're saying cognitive measures are the best predictors and orientation's too insensitive or too sensitive, overly,
Yeah.
whatever.
Yeah,
a ceiling
I hear
effect.
you.
And then you're basing it on some combination of other
Yeah.
neurocognitive measures. A lot of things can affect it. People can have sleeplessness, bad days, medication effects, whatever. So anxiety, what is the stability of these measures in terms of their predictive validity?
Well, I would say because the impairments are generally quite significant at -1 SD or more, that they bounce around a little bit, but the impairment stays there. They do not suddenly get better. Okay. Now, so you've seen that there are impairments, and by the way, these impairments were most evident in executive function and trail making. Simple working memory was relatively intact. And so what we found in terms of atrophy for the trail making test, that the superior frontal gyrus was a major player in determining performance. And as you may recall, that's where the frontal eye fields are. And some very elegant cognitive science work that basically no one knows about from Germany showed that trail making is not about psychomotor speed, but it's really about systematic visual search that's generated in the frontal eye fields. That's where the executive component comes. We also looked at our executive function measures, and we had some very nice relationships with DLPFC. Now, do these measures have anything to do with everyday function? If you're impaired on them, does it exact a cost? We used the UPS, I'll come back to that, and the answer is yes. And executive function in particular seems to exact a cost in everyday function. So to answer the questions that we laid out at the beginning, that working memory and executive impairments are frequent in amnestic MCI, there's a neural substrate to them, and that they do, in fact, exact a cost on everyday function. Okay, so again, the bottom lines. So let me talk a little bit now about some work specifically on episodic memory, which is a key component of Alzheimer's, and also semantic memory, which involves the knowledge system. And these are clinical pearls that are helped in a minute, is more impaired than letter fluency. We asked the subject to give you as many words as they could think of, starting with the letter, let's say the letter F. Okay? So here is memory after delay is more significantly impaired than immediate memory in AD. And we wanted to bring this kind of clinical lore into a contemporary context using a test of episodic memory. This was the test designed by Dan Ragland that I thought had a lot going for it. By the way, Dan originally designed this for schizophrenia. It's been used in some schizophrenia trials. I told him from the go, which of course he didn't appreciate, that it's probably a better test in the Alzheimer's disease context than it is in schizophrenia. He wasn't happy to hear that, but he continued a very good collaboration. So the field, like I said, uses a lot of legacy measures. They get the job done, but I think we could do better. There's been some compelling cognitive neuroscience, and in particular, there's been convergent animal and human data suggesting that item encoding, in other words, encoding a single stimulus, is supported by perirhinal cortex in the medial temporal lobe, and that relational encoding that has to do with encoding the relationship between two stimuli or a context and an item seems to engage the parahippocampus and the hippocampus proper. And these medial temporal lobe, these MTL subregions, have been heavily implicated in Alzheimer's memory impairment and are, as I said, usefully targeted by the RISE. And simple item encoding, subject is asked to determine whether a thing they see on the screen is living or non-living. In relational encoding, they're asked to say whether one item can fit into the other. And then there's a recognition test, which simply asks whether a specific stimulus was seen before, and there's a more difficult associative recognition task, which asks the subject to determine whether a pair was seen as a pair previously. And what we found, this was a little surprising, that in particular, by the way, that's D prime, not Cohen's D, that MCI subjects showed very large impairments in memory after relational encoding and memory after and memory for associative recognition. As a matter of fact, on the latter, they did so badly that they were at floor. And this strongly implicates the hippocampus proper at even this early stage of the disease. And by early stage, I mean MCI. We also showed, in keeping with Dan's original hypotheses, that left rhinal cortex with item recognition and relational D prime was associated with the hippocampus proper. Okay, and I couldn't resist bringing in ApoE to this story. Would have been too much for me. So let me make a slight digression, and then I'll come back to the RISE in the context of ApoE. So I think probably everyone here knows that ApoE is the single largest genetic risk factor for late onset Alzheimer's disease. The E4 variant is associated with about a 3.5 increased risk for the disorder. ApoE in brain is a major lipid transporter. It's produced in astrocytes. It's involved in membrane and synaptic maintenance. It has a receptor binding region. It binds to a whole host of receptors on cells and also on the endothelium. I'll come back to this point, but it has the different isoforms have different affinities for one of the main receptors, and there are also differences in protein abundance, such that E2 isoform, which I'm going to talk about in a minute, has higher protein levels both in brain and in plasma than does E4. It's also involved in a beta clearance, it's a chaperone, and tau modulation. So, given the work done on E4, which has generally preoccupied the field for several decades, although without a great deal to show for it, in my opinion, I wanted to look at E2. So why is E2 important? So ApoE is triallelic. E4 is the risk variant, highly protective. As a matter of fact, it reduces risk of AD by 10% compared to E3 individuals. It's also the only types in cluster analyses not based on knowing ApoE genotype, but based on a profile of cognitive markers and CSF markers and MRI markers, and find, in fact, that E2 was overrepresented in a cluster that had an anti-AD high cognitive profile. In other words, you could think of that cluster, cluster 2, which had a high proportion of E2 individuals, as a resilience cluster. So now, coming back to the rise, in a small sample that we collected for pilot data, we showed that the rise is indeed, in healthy individuals, associated with ApoE genotype. Okay? And you could see that especially in E2 versus E4 comparisons, there are large differences, especially in the two conditions that targeted the hippocampus. Okay, now what about the second point that had to do with semantic fluency and that clinical bit of wisdom? Well, we were interested in semantic changes in MCI because we had identified some volumetric reductions in lateral temporal cortex. Lateral temporal cortex is considered to be a key region, probably the primary region for semantic representations. There were also a great deal of methodological limitations in prior studies. A lot of them involved overt retrieval and ambiguity in interpreting findings, whether they represented an access to semantics or a corruption of the representation itself. And I had also noticed that sometimes, not always, that MCI individuals seemed a bit perplexed in the run of general conversation. And we also had evidence to show that clinical language measures really were not related to functional compromises. So we tried to develop something a bit better. And here we capitalized on some very elegant cognitive science work that DeHaan did in quantity processing. And bear with me for a second, because this is going to be a little bit counterintuitive, but it's been replicated multiple times. What he found, looking at numbers, when he would ask, is the number 9 bigger than the number 5, the reaction time to that would be quite brisk. When he would ask, is the number 6 bigger than the number 5, the reaction time was slower. Now, on the face of it, everyone knows that 6 is bigger than 5 and 9 is bigger than 5. But he strongly argued and found evidence for this, that it's as if the quantity processing system, and perhaps the semantic system, as you'll see, has to recompile evidence using what amounts to a number line. So when things are close on a number line, it takes them a while to make a decision. When things are far away, like 5 versus 9, it's quicker. It's an easier decision. So we wanted to get something closer to reality, and we wanted to use size. So our thinking was that, in general, the decision about which is bigger in the real world, ant or house, would be easier than ant or key. And we also had some nice incongruent conditions. I'm not going to talk about those. They're in the paper. And what we found was some very nice interactions showing that MCI individuals and AD individuals were really impaired when it came to making these fine-grained semantic distinctions. They could make the easy distinctions pretty well, but the fine-grained distinctions really threw them. And this suggested to us that there were frank compromises in the semantic system. This was not about access to knowledge. It was about the knowledge itself, and size being one attribute of knowledge, being corrupted. And as I'll show you later, we also found that these results were tied to functional compromise in a way that the clinical measures of fluency were not. Okay. I'm going to talk a little bit about MCI in particular and what I had called diagnostic exceptionalism. And it goes, the story or the anomaly that got me going on this was the fact that individuals with MCI who were amnestic had preserved everyday function. Yet, in every other neuropsychiatric disease, a significant cognitive impairment is associated with functional competence compromises. And that includes Alzheimer's disease itself. There really, in my mind, was no reason for this. And as a political aside, if you think about American exceptionalism, there's really no reason for that either. I mean, most of the time it just gets us into trouble. But there's no reason that there should be a sudden jump in functional competence between MCI and AD. So one possibility has to do with the sensitivity of tests used. So in most studies, not all, but in most studies prior to ours, people had used an informant-based measure. In other words, they ask a spouse or an adult child about how the patient is doing. Turns out the informant has biases. Generally, the spouse does not want to give the patient a bad grade. They they think the patient is doing better than they are, and they often say, well, I'm doing it for him now, but I know he could do it if I let him. Well, maybe, maybe not. The advantage of using a measure where you objectively examine the patient's performance using proxies, I think, are too great to overlook. So you could use salient real-world scenarios. A performance-based measure isn't subject to informant biases. No informant is necessary, of course. And the psychometrics in terms of lack of ceiling effects in relatively healthy populations and test-retest reliability may be quite good. Now, the usual rap against this is that, well, the performance-based measures are cognitive, but to my way of thinking, that's a plus. I mean, because most people do try to think when they're negotiating real-world tasks. They don't do these somehow in a fog, not if they want to complete them successfully. So we decided to use the UPSA. This measure was developed by Tom Patterson, popularized by Phil Harvey, and it assesses communication, including scheduling a medical appointment and remembering what to bring to a doctor's office, when to bring it, some comprehension and planning, including saying what you need in terms of planning a trip to the beach. It also uses a lookup table to determine the right route to a given town, and then in terms of finance, it includes writing a check to the electric company based on an overly complicated bill of the type that most people do receive. We looked at it in MCI. Here's our staging criteria, very typical of the field. And what we found, because we compared this directly, our measure, the UPSA, to a well-established informant-based measure called the ADCS-ADL. And what we found was that the UPSA, perhaps not so surprisingly in MCI, was more sensitive than ADCS-ADL. And here you could see the effect sizes, that the UPSA had an effect size of nearly 1, I think it was around 0.8 or 0.9, and the ADCSL, a widely used informant-based measure, had an effect size of about 0.4. Not trivial, but not as good as the UPSA. In terms of cognitive predictors of the UPSA, we found trail making, which, as I said, beyond it being a measure of speed, may also engage superior frontal lobe regions, logical memory, digit symbol, and other speed tests. And there was also some variance that was either unexplained or due to demographic factors. We have now looked at the UPSA over time. And in keeping with our hypotheses, the UPSA did decline over a year, and this was more or less correlated with declines in mini-mental. It's the first study to look at the UPSA in this population over time. Now, as I mentioned, remember that very nice episodic memory task called the RISE that was correlated with UPSA performance. And we also found, looking at our semantic memory measure based on distance effects in the semantic system, we also found that that could be related to the RISE. So what we think we have here, and by the way, I hope, Jeff, is showing a mousetrap politically incorrect to this audience? Okay, good. I didn't want it to bruise anyone's sensibilities. I wouldn't go that far, but I might get close to it. So we think we have a better mousetrap with the UPSA. The magnitudes of impairment in everyday function are, the magnitude is quite large in our MCI sample, and we also see decline in the MCI group as well as an AD group. The performance-based measure is more sensitive than the informant-based measures. I also didn't talk about it, but it has robust psychometrics in terms of skewness, kurtosis, the absence of ceiling effects, and test-retest reliability. We could also show that the functional and cognitive domains are systematically related. And potentially, and I think this is important, this could improve clinical trial readouts. Currently, I am involved with Critical Path in trying to get this qualified with the FDA as a measure to be used in early stage Alzheimer's. Okay, and now one last thing. And this has to do with practice effects in the context of clinical trials, and it really has to do with serial test administration in general. So, a while ago, probably about 10 years ago, we had suggested that cognitive impairment improvement or enhancement with second-generation antipsychotics, and this is in the schizophrenia clinical trial world, was really not due to the enhancing effects of the drug, but reflected a practice effect. And since that study, numerous studies have replicated. Our study was inferential. There have been several better studies, but they have shown the same thing. So now, in Alzheimer's, as the field is moving to generally intact individuals, a practice effect would not be unusual and it would not be unobserved. As a matter of fact, if you go to the literature like we did, it should be around 0.25. Now, a 0.25 practice effect is actually larger than the planned effects of drug. That could be a problem, and I'll tell you why. So, before I do, let's take a look at what the usual response is. The usual response is, well, you're being silly, there's a placebo group, and the practice effect in the placebo group will be compared to the practice effect plus drug effect in the active treatment group. Well, that's not correct for a couple of reasons. First, the practice effect adds, unarguably, error variance because people have different degrees of practice effect. And in some nice modeling that Adam Chiareglio here did, you could see the loss of power with increases in variance. That could produce a type 2 error. A type 1 error is also possible. This is what happened in schizophrenia, where a practice-related improvement was misinterpreted as a real effect. This had also something to do with comparator drugs used and perhaps a sponsor effect. Now, there's also an empirical reason to do this, and that is that those studies that have directly compared a test that doesn't show a practice effect versus those that do show practice effects have found that the practice effect is more sensitive to drug, and drug in these cases being either amphetamine or a cholinesterase inhibitor. Practice effects also, almost unavoidably, lead to neurobiology being misaligned with cognition. Okay? So if someone is actually showing neurobiological worsening, say there's increasing atrophy, and yet there's a practice effect, those two things are not going to align very well. So in my usual way, I wanted to take this head on and try to develop some measures based on cognitive science and my own thinking about how to directly reduce practice effects in serial assessment. And we wanted to use executive tests with restricted sets of items and no problem solving. This would create high interference, so there'd be very little carryover. We also wanted to have alternate forms that were equivalent. A big problem in the field, sorry to get technical here, is having alternate forms, but they are not equivalent in difficulty level. So that introduces noise as well. And we also thought that having an episodic memory test that reduces encoding strategies by forcing people into one encoding strategy would be helpful. And then we wanted to assay appropriate cognitive domains. So far, the NOPE battery, that means no practice effect battery, seems to be holding up well in terms of deliverables. We've had high test-retest reliability in healthy controls and an MCI sample. We've shown a sharp reduction in practice effects over 3 serial assessments. We also have a very nice and interpretable factor structure. And in studies we've done in MCI and in schizophrenia, where basically we've looked over 3 time periods, we see very flat lines indicating no practice effects. Now, you might say 2 things. One is that, well, maybe your group was not representative. Maybe this is a group that for one reason or another cannot show a practice effect. It's not the case. We also gave a test known to show practice effects. That is a verbal list learning test called the CVLT. And you could see the massive practice effects that are healthy controls generated and also very solid practice effects that the MCI group generated. Perhaps the MCI finding is a bit surprising, but in a very strong study from Jennifer Manley and her group, she showed that impaired patients, MCI and AD, actually could generate a practice effect that was quite substantial, perhaps surprising, but it's a very solid study. So here are some of the measures we used. Note that our recognition and free recall from our memory test is very nice and very flat. Also, you could note the large differences between our healthy group in blue and our MCI group in green. That's as it should be. The MCI sample is certainly impaired. We also use letter number manipulation, and I didn't show you the NBAC test. We used the one-back version, which is relatively easy. Here's the factor pattern that we showed. There seemed to be 4 factors. one involving working memory and executive function, a large cognitive control and speed factor, a target detection factor, and of course a memory factor. So, one last thing before we wrap up. As some of you already know, I'm a tennis aficionado, and every once in a while, watching a tennis match and you see something interesting. In this case, it was a tattoo on this top 10 player's forearm, and the tattoo said something to the effect of "fail better." It's a Beckett quote. And that's apropos to this talk here, because what I'm trying to show you is that the work we're doing is highly iterative. We already know that our tests are imperfect. Over time, we would like to make progress by making them a little less imperfect. I'll stop there, and I'm happy to take questions.
Terry, thanks. It occurred to me when you're talking about practice effects that the ability to benefit from a practice effect is an indicator of whether there's progressive cognitive decline in and of itself.
So, the question Jeff asked is important. People have looked at that, and those individuals who can generate the largest practice effect actually show the lowest rates of progression. Whether they're misdiagnosed or whether they're right at the cusp of impairment is unclear. But that is a point, and you could use practice effects to help you diagnose, in effect.
I have a couple of thoughts. I'll just ask one of them and then take questions. So when you showed your first slide with all the different biomarkers or potential predictors, and then found that the cognitive measures were the most informative, and then ultimately the OPSA. So if you factor in amyvid or any of the newer radioligands, does that change, or is still cognitive measures the best?
The CSF measures of A beta, tau, and p-tau are pretty reliable. And you might be able to do a bit better by looking at, let's say, for tau imaging. I think we're using the Merck compound here, the Merck ligand here, maybe by looking at Brock stage in particular. Perhaps looking at certain key areas with amyvid, let's say posterior cingulate and precuneus, may be better than some sort of global CSF measure. So yeah, I think it's possible, again, to improve those. But when people have looked at this meta-analytically, in general, cognitive measures hold up quite well.
So basically, there's no biomarker that's a better predictor than a clinical measure of cognition.
At this point, right, in my view. Now, but what's important is the biomarkers do work. They predict. They may not predict quite as well.
Okay, well, just to pursue this one more iteration, schizophrenia researchers, sort of try to emulate Alzheimer's research, and the whole MCI equivalent, attenuated psychosis, prodromal, has produced pretty middling findings in terms of rate of progression and predictors of who will progress. So it's 30% at best, but actually much less. And in terms of predictors, there's no great predictor to reduce the false positivity. And so they come up with a calculator, which is basically an assortment of things, which, to our way of thinking, really, there's really little meat there. And there's the individual elements within the profile of measures carry most of the variance, in terms of the attenuated psychosis measures. Anyway, in AD, are you finding that a combination of the measures increases substantially in a way that would clinically be meaningful, the predictive validity?
Well, yeah, so empirically, you could start with probably any given predictor will give you an AUC of maybe 0.65 to 0.70, and then you could increase it by adding in other markers, biomarkers, up to or a bit above 0.8 by doing them all in combination.
Well, I'm going to make a comment, but don't answer it because I'm taking too much time. I doubt that this is a standard part of the workup for people who show MCI and are suspected of possibly having dementia. But hold that for a minute. We should give Dev the first word because in my introduction when I said we recruited Terry here, it was really at Dev's instigation. So, Dev?
You're saying he's to blame.
Exactly.
Thanks, Terry. That was a very nice talk. I hope in our group, when we meet every week, you also speak slowly and clearly and convince all our students and research assistants about the value of these new tests you have. In listening to the first part of your talk about orientation, I was reminded of some studies we've done over the years. About 20 years ago, with our ECT program here, we found that the time to orientation following recovery from the anesthesia and seizure was the strongest predictor of your memory test performance 3 months later, 6 months later, 1 year later. Then the other thing, sort of unrelated, but it's really the same paradigm. You know, we are doing this study with olfactory identification, which is one of the biomarkers of Alzheimer's, by giving an atropine nasal spray challenge and seeing how your olfaction test performance drops. It drops in everyone, but the people who drop the most have a cholinergic deficit and may respond to treatment, or it could predict what happens over time. Do you think using these types of challenge procedures or looking at acute effects in normal people, normal older adults, when we give all these tests, including yours, they often have ceiling effects, they just do well. Would that be one way to figure out who is likely to develop MCI or Alzheimer's in the long run?
I've always liked challenge tests. And by the way, I think the ECT finding could be considered a challenge test too, in a sense, that those people on the cusp of bad memory were most compromised by ECT and had a slower, quick recovery. But I think challenge tests are very useful. You know, from Trey Sunderland's work with the muscarinic antagonist to your work, I think they're useful. They're interesting, and they could tease out very subtle impairments in people who would otherwise do quite well on a whole host of measures. The question is, what would be an appropriate challenge? You know, are there other neurotransmitter systems that might be more sensitive, let's say, than the cholinergic system, for instance?
But wasn't that what Peter Davies and Ken Davis did initially with atropine as a measure of cognition?
Well, Robert Katzman did a study giving scopolamine to elicit cognitive impairment.
Right.
We tried it here,
and those were the
we had
studies
trouble
Trey
with
did.
it. Yeah.
Yeah.
But the cholinergic challenge idea is still around. It sort of works, but I don't think it's been paired nicely with the neuropsych test because you need to do it very quickly.
Yeah.
And all your tests, I don't know about all your tests, Terry, compared to the standard ones, they take too long. And then there's decay over time, and you want to capture how that person performs in a very narrow time frame, your challenge, and then repeat it.
Yeah. Some of the tests are short.
Yeah.
Some are longer, correct, but they could be adapted as well.
You know, just a point of historical information is that when Tim Crow, way back in the 1980s, came up with this type 1, type 2 hypothesis.
The age disorientation.
Right.
Right.
That's what was the distinction.
Yes. Yes. Yeah.
Alex?
So it was very, very nicely show the difference, the group differences, sometimes predictive, sometimes not. But the thing that I can't get away from wondering is what the actual decay looks like over time. And I don't know how much longitudinal work has been done and how detailed. And so the question is whether any of these measures, be it semantic or working memory or anything else, shows any type of a qualitative drop rather than just a difference in the slope of decay.
By qualitative drop, I mean, there are, for instance, in ADNI, there have been, people have been studied now over 5 years. In ABLE, a large study in Australia, the same, obviously, industry has a lot of studies. So these measures do decline, and more or less in concert with progression.
So it's just mostly an increased slope rather than at any point a sharp drop off.
Correct. The only thing, and this is a little bit grisly, is that people in Chicago, looking at the religious orders study, namely Dave Bennett and Bob Wilson, have shown that in almost any individual, in the 2 to 3 years prior to death, there's a sharp drop. That slope differences change.
Is the MoCA, is that like the equivalent of demand, cognitive demand, to like mini mental state? Or?
It's absolutely the equivalent of mini-mental.
Yeah, so it's a pretty low threshold. There's a ceiling effect.
Yes.
Yeah.
And also, it's not designed to assess personality disorders.
Okay, let's remember the goal, water roll.
Stop. I hear you.
Let me ask, just try. Well, we're going to take David's question in a second, but I just want to move the discussion in a slightly different direction. So, the emphasis that I think we're trying to bring out, and this is actually something that Barry's been involved with historically, is not so much the focus on late life diseases, but really healthy aging and preservation of mental function, quality of life. So it was recently, Maura had a paper in Cell that was on the director's blog of the NIH, commenting on the fact that there's active neurogenesis and cell viability and reproduction going into adult life. I mean, late life senescence. And that, so one would assume that this likely has some relationship to cognitive function, through the aging process. But we don't have radioligands like a BDRU for measuring new cells yet, do we? So I'm wondering how, this sort of aging process and cognitive function and being able to identify the neurobiologic substrates, whether there's, any sort of imminent or reasonably foreseeable way of sort of drawing these things together in some way. That's a question for you, Terry, but also for more Brett, Dev, and Barry to comment on if you want.
Well, I mean, in terms of my work, some of the work that I have planned is taking a very hard look at ApoE2, the genotype, and also plasma ApoE levels, which nicely monitor brain levels of ApoE, and in order to see what effect they have on a whole host of biomarkers and cognitive markers in terms of brain resilience.
But wouldn't ApoE, as a genetic marker, indicate a trait-specific
Yes.
phenomenon? So it tells you who, but not when.
Yes, correct. Correct.
So how's that going to help?
Well, one thing is that you could create a biologic age from ApoE to plasma ApoE and some markers to help, let's say, primary care physicians determine. You could also possibly manipulate plasma ApoE.
But does plasma ApoE fluctuate in relation to some aging, dementing, cognitive decline process?
Not really.
Maybe I'm missing it. I'm not
No,
sure
it
how
could be
that's
that-
informative.
That's not, yeah.
comments? Maura, Brett, Dev? Dev, you go first.
I think in translating Mara's work in animal models, the problem with human imaging, although we like it a lot, John Mann was here, but he isn't anymore. The resolution of what we have with PET scanning is in the order of millimeters. And if you talk about new cells being generated in humans, especially in older people, we just don't have that resolution. So it's really not so much finding the right ligands, because there are plenty around, but to get it into enough good shape in terms of resolution that you can actually pick it up in humans. So when we look, say, at amyloid imaging or tau imaging, there has to be a lot of amyloid, a lot of tau to pick it up. And when you're getting neurogenesis, the percentage of extra cells that you're getting is so small, it's really tough to pick it up. But I suspect over time, the technology will improve to the extent we can actually do it.
What about olfactory biopsies or some measure of olfactory bulb function?
Olfactory bulb function, some years ago, we tried to do MR scanning. I think when we got the 3T scanner here, it was very hard to get a good enough resolution, but the olfactory bulb is a very small structure. There are papers in the literature from Germany saying they can do it easily. I'm just not sure how they do it.
What about CBV and MRI and the behavioral readouts of some of the stuff that Adam and Scott are involved?
We're going to get to you, David.
Oh, and I know you've done some work in this stuff, so I wondered what you thought. That it seemed to me, Scott Small's CBV fMRI and looking at evidence of synaptogenesis or neurogenesis in the dentate, along with some of the, like the ModBent and some of the things Adam Brickman and people have come up with, it, combining behavioral readouts of dentate function with CBV fMRI might be kind of getting us to the methodological sensitivity we need to be able to document neurogenesis now in vivo. But I guess in thinking about your question, Jeff, there's kind of a dissociation between normal cognitive aging and where neurogenesis occurs and where the deterioration is in Alzheimer's. So they're kind of occurring in different areas, right? So I'm not sure it's entorhinal cortex versus dentate. And so I don't know how to directly, they're kind of parallel processes going on in different regions.
And also CA1 in Alzheimer's is also heavily hit.
that's-
Jeff, let me come back to your question, and this probably more is best able to address this. What about BDNF, its supposed relationship to neurogenesis, and then being able to manipulate BDNF either pharmacologically or through exercise?
This paper, we studied people with no cognitive impairment, no MCI, no Alzheimer. So the new neurons that we find up to into the eighth decade of life, they are in the order of thousands out of millions of dentate gyrus neurons, the mature ones. And they didn't decrease with age. But vasculature, it goes down quite a bit with aging, although the neurons are still there. So yes, the correlation between angiogenesis and neurogenesis, we've seen it before, like in studies where we look at the effect of accessorize, they both increase together. So it goes very well with Scott Small finding correlations between neurogenesis and angiogenesis. In this case, with aging, maybe there is a decline in vascularization before you get the decline in neurons. And yeah, I mean, the MRS findings we had with Dr. Devanand, like we looked at the MRS stuff, and I've seen that the group of Mariana, they had there was this paper, right? And now they are reproposing the methodology studying adolescents. There was a poster at the ACMP, and I know now there is a grant in and NIH to look at that. So I don't know how much progress has been done with that kind of measure, but it seems like they are trying to repropose, at least in adolescents where the neurons are more, maybe it's more sensitive, but yeah. And for the trophic factors, yes, we are studying VEGF and BDNF in these brains. So when we have the data, we have data in depression versus control right now, but we don't have the aging data. But when we look at that, trophic factors make a lot of sense. And yeah, thanks.
Just for the record, since over the years there's been some controversy, right now the only real solid evidence for new cell production in adult and later life is in dentate gyrus and olfactory bulb.
Has been shown that maybe in human olfactory bulb does not continue to produce neurons as the dentate gyrus, and probably because supposedly humans, we don't use the olfactory bulb as much as mice.
But the work that was done, I forget her name, at Princeton, and then Pascal Rakich savaged her about cortical,
Elizabeth Gould.
yeah, cortical,
Yeah.
that's never panned out, right?
I think that's correct.
David?
So let me ask something messier because you're an interesting guy and maybe you can comment on it. There's been findings lately that as people get more demented, they degrade in their sense of humor, which interests me in terms of like ranking humor. And I consulted the neurology department, and I've been talking to them a lot about where do you get a joke. And they think it's far beyond the hippocampus. You got to use your cingulate gyrus. And not only that, but the right frontal lobe in FTD, frontotemporal dementia, is very important, or else you get Wisselsucht, a really degraded humor. And on the other hand, people might have multiple system atrophy. They might have the whole base of their brain totally shot, and there's no activities of daily living, but yet they can get jokes. So there are these huge brain regions that are involved with with humor, which is like comparison between two incongruous things, or exaggeration, comparison between something as it is and something that's exaggerated. So where is it?
I've looked at some of the humor literature, mostly in FTD. I haven't thought very much about it in the Alzheimer's spectrum, but it's interesting. It's definitely interesting, and I don't think now I could sort of localize it to a neural system. So I'd like to sort of punt on that question and then get back to you when I know a little more.
You can spend a lot of time at the Friars Club and maybe a little bit of exposure. But I mean, there are a number of conditions that are associated with punning or with...
That's the Wisselsucht type thing, the kind of silly jokes.
Yeah,
Right?
yeah.
Yeah.
Brett?
Well, maybe just taking off on that point a little bit, and Terry, we talked about thanks for the great talk, by the way, I really enjoyed it. About this recent grant that I submitted that we collaborated on, thinking of, and we didn't get, it's a little adjacent to your talk today, but the cognitive contribution to emotion processing. And especially if we think of when MCI people start to diverge from normal aging trajectories, that emotion processing might be a kind of sensitive measure to look at in that zone, because we normally think of getting wiser and happier and more focused on positive affect as we age, and that the kind of hubs of the early amyloid network, like orbitofrontal cortex and amygdala, kind of being very relevant for emotion processing, that perhaps disturbances in kind of emotion regulation and cognition-heavy emotion processing, processes could be early indications of early risk factors and indications that you're kind of falling off of a positive aging trajectory.
First, I agree, and it's been totally under-researched. So, you may be onto something.
We're going to have to stop in a minute, but beforehand, Barry, do you want to make a comment on any of this?
Sorry. I would like to know, could you explain why it is that people who are fairly dementing, maybe in nursing homes being looked after, can still recite songs. Once you strike up the tune, they'll fit in. Which part of the brain is responding to the need to recall memory?
I think there are regional vulnerabilities to Alzheimer's pathology, and occasionally the pathology will leave a region, let's say posterior right hemisphere, where there may be some rhythm and melody preserved. And that would lead to this knowledge being recited because the area happens to be intact among a very large area of compromised tissue. So occasionally you see these splinter abilities, people being able to track their golf shots, for instance, can still play golf. Now, obviously that's driven in part by basal ganglia, but the fact that they still know rules to the game in some ways is impressive.
Okay, Dr. Lieberman had to leave for a meeting, so I'd like to thank Terry for a very nice talk. It's quite different from how we do things, the topics, and I think it was really informative. Thank you. Thank you all.